Hello, my name is Nadia Bey. I'm a rising junior at Duke University studying biology and global health. And this summer, I worked with Dr. Janet Becker and Dr. Rebecca Whitaker as part of a project funded by the KP Reynolds Charitable Trust, in which we're examining disparities in telehealth access, primarily for Medicaid beneficiaries. I conducted a literature review on the factors impacting the use of telehealth for people with musculoskeletal health conditions. First, to give some background, musculoskeletal conditions impact approximately 1 in 2 American adults, so make up a small portion of telehealth visits, and that's true at the adult and pediatric levels. Telehealth uses increased during the pandemic with loosened HIPAA and payment regulations for public insurance, and that's thanks to Telehealth 1135 waiver. Despite this expansion in access, there are still disparities in use. Telehealth users are more likely to be younger, white, female, higher income, and English speaking, and fewer comorbidities. Therefore, the goal of my literature review is to understand patient and provider experience with telehealth for MSK and identify disparities as well as potential causes for those disparities. Before going any further, I wish to define telehealth. Telehealth or telemedicine is the asynchronous or synchronous transfer of health information between patient and provider. This review primarily focused on synchronous methods such as video conferencing, audio-only visits, and telephonic visits. I also conducted preliminary research to identify some of the most common MSK conditions using peer-reviewed sources through PubMed, as well as the fourth edition of the Burden of Musculoskeletal Diseases in the United States. I also used PubMed for my primary literature review, and the MSK-related search terms I used included disability, physical therapy, orthopedics, and physiatry. The populations of interest I selected had the highest burden out of all MSK conditions, as well as some of the highest costs. And those conditions are low back pain, osteoarthritis, and rheumatoid arthritis. Low back and neck pain are some of the most expensive conditions in the United States. And osteoarthritis comes in at number 8, while rheumatoid arthritis comes in at number 26. I also identified 3 subpopulations, and it's based on what I noticed in the literature. The first subpopulation is pediatric patients, and I selected pediatric patients because juvenile rheumatoid arthritis is one of the most common forms of arthritis in children, and pediatric patients often have different treatment standards from adults, which is something that should be taken into consideration. The second subpopulation were people of color. Black people often have higher rates of radiographic osteoarthritis than white people, and systemic racism can often contribute to poverty and disparities in access to technology and the infrastructure needed to participate in telehealth visits. My third subpopulation were workers, since certain occupations are more susceptible to low back pain and osteoarthritis based on their daily work activities. The key points of my literature review were that patients primarily accept telehealth as a supplement rather than a substitute for in-person care. Or for example, pediatric rheumatology patients preferred face-to-face care for active or worsening conditions. For certain occupations like farm workers and truck drivers, they were receptive to telehealth and had the infrastructure to do so, but there wasn't much research on their experiences with telehealth. Some barriers to implementation include the inability to perform physical exams or collect anthropometric data such as height or weight. There's also absence of clinical guidelines for virtual MSK assessments. Reimbursement and billing were also major challenges for implementation of telehealth, as well as funding for infrastructure. Similarly, on the patient side, broadband access, basic literacy, health literacy, and technological literacy pose barriers to use, as well as language barriers, since bilingual families are often excluded from research studies on telehealth use. Additionally, telehealth visits for MSK have decreased as providers shifted back to in-person care after the initial lockdown in 2020. And it actually turns out that patients may be less aware of telehealth offerings post-reopening. So based on what I found, future steps include developing mixed models where patients are able to travel to telehealth-equipped locations for appointments. And these mixed models can address broadband issues and allow access to services not available locally. Additionally, providers and patients receive training on how to use telehealth technology. Public and private insurers should adopt clear payment policies so there's no confusion about reimbursement or billing on the provider's end. Patients should be made available of telehealth offerings through multiple mediums, such as the internet, phone, snail mail, all sorts of methods. And lastly, further research is needed on the use of telehealth for work-related MSK conditions. I'm really grateful to Dr. Becker and Dr. Whitaker for their mentorship on this project. Catherine Norman for her perspective on musculoskeletal care, the KBR project team for their insights, the Duke Global Health Institute for their guidance on making the most of my experiential learning activity, and the Duke-Margolis education team for making this possible. Thank you.